This week on the BackTable podcast.
Using Mentis and a lot of the AI softwares in trying to mimic the procedure itself has been a game changer. Many people are able to practice on Mentis, which is an AI platform coupled with a catheter that mimics the whole procedure and gives you the tactile feel of maneuvering an ICE catheter and giving you the images that you're looking for, as if you're in a procedure. So you perhaps can practice outside the procedure room for 15, 30 minutes, 1 hour, and then you can go and do the exact same thing that you've done on the Mentis device, but in the patient.
Welcome everyone to another episode of BackTable Cardiology. I'm your host, Sayfo, interventional cardiologist from Dallas, Texas. I'm honored and privileged and really happy to have our guest today, my colleague, my friend, Dr. Karim Al-Azizi. He's an interventional cardiologist, a structural interventionist at Baylor Scott-White, the Heart Hospital Plano, from the heart of Dallas. Thank you, Karim, for joining us today.
Thank you, Sam, for hosting me tonight.
So today we're going to be talking about a very interesting topic, the evolution of ICE, intracardiac imaging, echo in structural heart disease. So before we start, Karim, can you give us your background? What made you interested in structural heart in the beginning, and what's ICE?
Thank you, Sam. Thank you for the kind introduction. So my interest in structural heart really came much earlier on in trying to figure out solutions for the heart that may be done in conjunction with either minimally invasive surgery or just completely transcatheter approaches. And actually, early on, I considered either going through the pediatric route, as I was really attracted towards the pediatric interventional creativity of potentially treating these young pediatric community that may have congenital defects or perhaps valvular disease. But as I continued to learn and understand what can be done with even with the adult heart and the continued evolution of the technologies that are coming into light and the immense need actually for transcatheter options, especially for patients that cannot tolerate open heart surgery, that drew me really into the treating the adult world, and hence advancing more into education and learning more about structural heart disease. And here I am today trying basically to help the community with all the transcatheter options available.
So Karim, tell us why you're interested in structural heart. For the audience, when they listen, the general cardiologists, when they listen to the word structural heart, in the past, structural heart was PFO, ASD, VSD. But nowadays, structural heart means a little bit more in the adult world. What are the other diseases that you see in the clinic that is included in structural heart?
You know, Sam, as you mentioned, the field has evolved quite a bit. And I think one of the biggest evolutions in that field is actually valve replacement or valve implantation. Starting with the transcatheter aortic valve implantation, really a journey that started now over really 15, 20 years. And here we are today, doing 3, 4, 5, or 6 patients a day with the next day discharge. This has led to us to think about other solutions for the other valves in the heart, like the mitral valve, the tricuspid valve, and potentially even think about repair options. And now, fast forward, we're doing transcatheter, mitral, and tricuspid repair. There have been other technologies of replacement as well in those patients that may not be repair candidates. Many of them are still under clinical trial. But even more than that, Sam, the community has worked together to actually MacGyver and come up with solutions for patients, for example, with hypertrophic cardiomyopathy, for example, utilizing electrosurgery by electrifying a wire using BOVI and perhaps creating myotomies within the muscle itself in order to alleviate LV outflow obstruction in those patients, for example, that can't get heart surgery or not good candidates for open heart surgery. Many other options like left atrial appendage occlusion, and a clear alternative and something that has been shown over and over again that it is as good as anticoagulation in preventing strokes related to atrial fibrillation minus the risk of bleeding. So, we continue to evolve. We continue to actually maneuver things within the heart, replace valves, replace the functions of valves, and create or make room for other technologies to perhaps help aid the patient, either improve their quality of life, improve their outcomes and longevity, or even both.
So if we're gonna make it simple, we can think about the heart in three different ways. We think about the heart as coronary artery disease, basically we joke about it as the plumbing. We also think about the electrophysiology, that's electricity, and anything else that's related to structure of the heart, from fixing valves, closing holes, and sometimes actually opening holes for the heart failure. That, or as I said, alcohol septal ablation for hypertrophic cardiomyopathy, all comes under the same umbrella. And as part of the structural heart from the beginning, there was an understanding of the importance of multidisciplinary approach and different specialty, including imagers, where transesophageal echo, which I think most of the audience understand what that is, where transesophageal echo help getting a lot of images. But what is intracardiac echocardiogram? What's ICE?
Intracardiac echocardiography is a tool really that has been around for a while. And in the form of 2D echocardiography or ultrasound waves, a catheter is being introduced through the common femoral vein, sometimes through the internal jugular, but mostly through the common femoral vein, to go up through the inferior vena cava, sit in the right atrium, and then you start visualizing the structures of the heart. Intracardiac echo, with all its forms, just like ultrasound probes, just like ultrasound technology, has evolved where you are able to perform multiplanar reconstructions or derive different dimensions or images, or even have a 3D image of the structure you're looking at. The same thing has evolved for intracardiac echocardiography. And we have seen now, your typical famous vendors like Philips, GE, and Siemens develop their own ICE catheters that are now competing in order to provide the best solutions, perhaps in guiding interventions, Sam, without needing to go under anesthesia for transesophageal echocardiography, or sometimes if imaging through transesophageal echocardiography is challenging due to shadowing, intracardiac echocardiography or ICE can be very helpful and complementary to transesophageal echocardiography.
You're reading my mind. So if the patients have some, for example, esophageal issue that you cannot introduce a transesophageal echo, or when you need a transesophageal echo, that means you need another physician in the room, and maybe all patients are usually under anesthesia. So do you think intracardiac echocardiogram maybe make it easier to perform this procedure? Does the patient still require anesthesia, or that's an option?
It depends on the procedure, Sam. For example, let's take, left atrial appendage closure and the evolution of left atrial appendage closure. As we've known and learned to do this procedure, it's done under anesthesia, general anesthesia. There's an anesthesiologist in the room. There's an imager in the room to perform the transesophageal echocardiography. The patient has a central line, has an art line for monitoring, has an endotracheal tube, and a ventilator for the duration of the procedure. If you think about it, that's a lot of resources for a preventive procedure. And now, fast forward, now we have ways where we perhaps can have the operator become also the imager, provide some sort of anesthesia to those patients with moderate sedation, while the patient is breathing on their own, a lot of local anesthetic, and everything else is basically done through intracardiac echo guidance, with the catheter even delivering the device through the same common femoral vein, without having to invade the patient's airway or mouth, without having to put additional lines, without having to have additional personnel, and perhaps save these resources and team members for maybe more complex procedures, because of the fact that we have to realize that there has been an increase in demand in all these team members in the rising prevalence and incidence of heart disease in general. So if we can spare these resources for where they're needed and perhaps show that this way of doing it can be safe and efficient, then the patient, the physician, the community, the healthcare can win at the end.
From the structural heart disease spectrum, what are the structures that intracardiac imaging or echo can really visualize well, and you recommend physicians to start using as beginners? I'm not saying someone who's a lot of experience, someone who just wants to start using it. What are the easiest ones to use initially to learn the basic of ICE?
When I started, Sam, with intracardiac echocardiography, like we did, remember, we did PFOs, we did ASDs, we tried to understand what we're looking at. We started with basic standardized views, and then slowly we started to look at the other structures of the heart that we used to ignore since we really didn't have any therapies or any reason to really focus on them. And now, especially with the idea of having catheters where you can obtain and you can digitally steer your images without having to move the catheter position itself in the heart a lot, you're able now to guide and look at many things without having to do that. So building on the basics of understanding your basics of ultrasound, basics of your TE views, basic of even the structures within the heart, building on PFO and ASD closures, and slowly going into left atrial appendage closure. And while you're doing all of these simplified procedures or building on that, understanding the other structures in the heart, the mitral valve, the tricuspid valve, and perhaps familiarizing yourself with how things look like under intracardiac echocardiography.
So for the audience, if I'm understanding you well, understand it correctly, so the easiest one would be the ASD PFO, then you can expand to the left atrial appendage closure device, and lastly would be maybe the tricuspid valve and the mitral valve, and slowly learning it. What are the limitations of this technology? What are the cases where you say, maybe this is not the right case for this technology?
The biggest issue right now is, as you've highlighted, Sam, especially as we get into the complex parts of left atrial appendage closure and specifically guiding tricuspid tier, which are really the ultimate two procedures that we are, trying to use intracardiac echocardiography in it. The learning curve is one. And then the second thing is the cost of the catheter. Right now, these catheters are disposable. They are at additional cost. They're not reimbursed for. We use them in the name of efficiency, perhaps reducing procedure times, being a little more safer, but that has to be done in conjunction with the ability of actually getting those images in order to enable those therapies and actually have them do what they're supposed to do in a safe and effective fashion. The other thing is there's lack of data or direct data on telling us head-to-head whether TE versus ICE is actually better, safer, shorter procedure time, less resources, for example, a procedure like left atrial appendage closure. So on that note, for example, we are leading the first prospective randomized clinical trial comparing both approaches with left atrial appendage closure called the ICE-TEE study, ICE-TEE study, and that's meant to really look at safety and outcomes of those patients, the questionnaire on their how they felt from a comfort standpoint, but also looking at the resources used in this procedure. Tricuspid tier, there is emerging data that will be coming out looking at how the procedure has become a little more efficient. We know that tricuspid tier, for example, is a very complex procedure. If we think about mitral tier being a 101, well, this is a 501. And the way we think about it is that if there is some sort of imaging that will enable you to react faster and perhaps treat the patient faster, then obviously everyone wins. And so there is more emerging data that will come out in regards to that will give us a little more guidance and perhaps standardize things in the community on how to treat those pathologies.
Yeah. First of all, I would like to congratulate you and your team on really leading the effort on simplifying this procedure and make it more affordable. This is amazing work, and hopefully we can meet again after this paper is published or this study is finished and published and talk about it again. I think a lot of the audience really excited about hearing the result of this data and maybe can change the way they practice. But as you know, in cardiology training or fellowship, we learn echo, we learn transesophageal echo, but really ICE is not something that every program has, or even imagers maybe don't know a lot about ICE. So if someone who is a structural heart specialist or maybe an imager who want to learn ICE, what are the ways to learn ICE? Is it company-driven, industry-driven, or is it physicians like yourself? What's the possible way of people to go and learn it and bring it back to their hospital?
Sam, that's a great question. When I tried to learn the simple basics of doing a left atrial appendage closure with ICE, I've reached out through, obviously, the industry, and I was connected with a very talented electrophysiologist, Dr. Shepal Doshi, who was kind enough to come down and work with us and walk us through his algorithm. And based on that and building on that, really, over now 2 years ago, I think where we are today is amazing. And so it comes with, obviously, more and more practice. Nowadays, the resources are even more. Obviously, we have taken this on ourselves in actually providing training through whether the imaging companies or through the transcatheter therapy companies, to provide that as an additive training in order to go over the basics of imaging, but also the discipline of moving that ICE catheter in the heart for whatever procedure we're doing. The second is obviously that the society is trying to partner as well with industry as well as with physicians in order to potentially provide training camps for that on the skirts of the annual scientific meeting, for example, for SCAI, as well as many other scientific meetings. And in addition, there are many options for what we call proctoring and even reverse proctoring, where physicians can come down and spend a day with us, or vice versa, or physicians that have done these procedures and have the time, the ability, and are able to educate, have shared their time with other physicians in their labs in order to do these procedures and help them build those programs. So there are multiple channels, practical channels, because I will have to say, Sam, that even with our step-by-step life cases that we have done over the last couple of years, in order to break down the steps of the procedure, there is nothing more than actually doing these procedures yourself and taking feedback at the time of. That's one. The second thing, honestly, is that using Mentis and a lot of the AI softwares and trying to mimic the procedure itself has been a game changer. Many people are able to practice on Mentis, which is an AI platform coupled with a catheter that mimics the whole procedure and gives you the tactile feel of maneuvering an ICE catheter and giving you the images that you're looking for, as if you're in a procedure. So you perhaps can practice outside the procedure room for 15, 30 minutes, 1 hour, and then you can go and do the exact same thing that you've done on the Mentis device, but in the patient. So there are ways now that have actually helped improve the learning curve for such complex imaging aspect of, let's remember, this is not still the therapy, this is just the enabler for the therapies that are being provided.
You mentioned something that there are 3 companies that provide ICE probe and technology. Have you had experience with all of them, and what differentiate one from the other? You said Philips, GE, and Siemens, correct? Can you share with us your experience and what's the difference between the 3?
Yeah, when we wanted to adopt 1 or 2 catheters, in our healthcare system, to give it a fair shake, we tried all 3 catheters at the time. And, honestly, what dictates, Sam, what you would get is really what is your ultrasound machine systems that you have. Because as you know, you cannot use a GE ICE catheter and plug it into a Philips system. So a lot of folks, for example, in Europe, because they are mostly GE, they would utilize the GE ICE system. Here, Philips is much more common in the United States, and so a lot of people would tend to gravitate to that catheter. Now, nonetheless, both catheters are great. Called GE New Vision, and the Philips VeriSight. The Philips VeriSight is a 9 French that goes through a 10 French sheath. The GE New Vision is a 10 French catheter that goes through an 11 French sheath, so not really a major difference. Both are able and capable of giving you multiplanar reconstructions, multiplanar imaging with 3D imaging as well. Siemens catheter, there has been a newer reiteration that is coming down the pipe now and is being released. That is very exciting to see. But I think we're going to see more and more newer iterations of all these catheters that hopefully one day, A, the cost gets better, and B, obviously they can be reused in order to help with the cost of these procedures.
So for practical advice to the audience is, first thing, if you want to learn it, make sure you figure out what you have in your hospital, what device you have in your hospital, so you're not having to spend more capital just because or maybe you already have the machine, but you don't have the probe. Number 2, reach out to the industry partners and figure out how they can provide that. And more importantly is reach out to someone like yourself or leaders in that field to help them learning the right way, proctoring through society, through, courses or proctoring systems. So this is really helpful to the audience. I know you've been leading the force also in left atrial appendage closure device, and I'm not gonna spend, this is a whole conversation for like a couple of hours, but left atrial appendage closure device, now the two leading devices is Amulet and Watchman, two different companies. Watchman started with 2011, the Protect AFib, and then, Amulet came as an ID trial, and now both are available commercially. When do you decide for the left atrial appendage closure device, when do you decide to use, outside the study that you mentioned, to use ICE versus TEE?
We've narrowed down, really bring it down to the patient's characteristics. If a patient, for example, is a difficult intubation, if the patient is someone that doesn't have an esophagus because of a prior esophagectomy, if you have the ICE skill set, this is a very easy way to do this procedure without having to put them at risk or even perhaps sometimes deny them the therapy. There are certain instances where patients may be not really in good form or can't lay down with conscious sedation that you then may consider, well, let me put them under anesthesia, and hence you will be intubating them. And if you're intubating them, might as well use transesophageal echocardiography. More use for ICE and more reason to consider ICE, honestly. Older folks that don't want to get under anesthesia. We have many referrals for patients basically where they come with their kids and say, well, mom or dad were not the same since that last procedure when they went under. I would say, yes, that the length of the procedure is not that long for general anesthesia, but it's the repeated, obviously, exposure to general anesthesia that may sometimes affect patients, make them cloudy, perhaps even progress their dementia. But, with moderate anesthesia, the procedure is done within an hour. They go home, the same day a lot of times. So it's much lighter on them from a recovery perspective. Their loved ones are with them. They're not noticing that, the patient has gone under. And so I do think that has more reasons to consider than saying, well, let me just consider TE.
I think that's amazing to hear because, it's a 2A indication for the Watchman device, to the left atrial appendage closure device now in patient who cannot tolerate anticoagulation, which in same token, those are older patients with high risk of bleeding and possibly having a complication from anesthesia. So it's really refreshing to see that we can treat this patient with the same tools and we're not preventing them therapy just because we can't image them or put them under anesthesia. So you promised us at the beginning, prior we started recording, that you're going to show us really two interesting cases. One is a left atrial appendage closure device case via ICE, and one for a TEER, if I'm not mistaken. So you want to share those cases with us and take us through them.
Thank you, Sam. So I'll go very quickly over a patient, 72-year-old with multiple comorbidities, elevated CHA2DS2, and has bled. She's a fall risk, uses a walker, and had frequent falls, and she was referred for left atrial appendage closure. Part of the workup, as everyone may know, we have emerged now from just standard transesophageal echocardiography to CT scan. And in this case here, you can see the CT heart, and I'm performing my own reconstructions in order to get the left atrial appendage on FOSS. We're trying to get the actual measurements of the ostium as well as the landing zone.
That's for the audience, is a 4D CT heart, correct?
Correct.
And that will give you the sizing of the appendage?
Yes, exactly right.
What else would that 4D CT provide you in this situation, beside the sizing?
A lot of times it will tell us if there's any thrombus present in the left atrial appendage. Specifically, patients could not tolerate or even take any pre-procedural anticoagulants.
Perfect. And so that's helpful for a patient who cannot be sedated for the TE that usually they get prior to this procedure.
And honestly, Sam, we've even taken it a step further because especially in the variable anatomies of left atrial appendages, we're able to actually decide where to do the transeptal just from that. And there are now new softwares, for example, like Materialize's software, where you can predict the size, the transeptal that you need based on the patient's specific anatomy, and hence simplify the procedure, make it more predictable. And actually, the study Predict LAA came out and showed a benefit in favor of such softwares in helping us become a little more efficient and perhaps use or less exchanges of devices.
Excellent. Very, very interesting.
So the plan for this patient was to perform an ICE-guided single transeptal puncture, moderate sedation. What do I mean by that? we will stick the right common femoral vein under ultrasound guidance with 2 punctures. One would be for the Vericite ice catheter, which is in this case a 10 French sheath for the 9 French ice catheter, and the more superior femoral puncture is for the transeptal and the procedural axis for the device. Once access is obtained in the right common femoral vein, heparin is given in order to achieve an ACT of about 250. So those patients need to be anticoagulated in order to avoid any thrombus formation. Here you can see on the left the procedure and the fluoroscopy. Using my mouse here, I will try to simplify this. But essentially, in this area, this is the transeptal catheter. This is the intracardiac echo sitting in the heart. The patient has already multiple hardware, including pacemaker wires. And on the right here, this is the ultrasound image that you see. So if you can see here, what you're seeing is essentially the interatrial septum, and this is an X-plane basically coming through the septum in order to give you from superior to inferior, but also the other dimension of anterior and posterior. And so you're trying to identify the site of the tenting and the puncture of that catheter in the fossa before you perform your puncture and proceed with passing the needle and then the wire. So where does this look like fluoroscopically? You can appreciate here after we've done the transeptal, there's a wire that is coming from the inferior vena cava up through the right atrium, through the septum, into the left atrium, and out into the pulmonary vein. And you can see it here concomitantly in the ultrasound image on the right, seeing a wire that is going from the right atrium through the septum right here into the left atrium and heading towards the pulmonary vein. Obviously, the ice catheters in the right atrium can see it.
May I interrupt you just to clarify for everybody? So when you do transeptal for appendage, what quadrant in the septum you're looking for, and would the ice help you identify that?
So, that's the beauty of biplane or X-plane imaging, is that, as you aim for more of a posterior inferior puncture within the fossa, that's exactly what you're aiming for. But sometimes for chicken wing anatomy, you may favor a little more anterior puncture for those patients. And so it's really anatomy dependent, Sam, in order to decide where exactly you want to puncture, because by the time the catheter traverses from the interatrial septum all the way on to the lateral side for the left atrial appendage, the trajectory of that catheter changes. So it really depends on the shape and the anatomy that you're dealing with. So what happens here as you can tell, we were imaging from the right atrium because you can see the left atrium on the other side, and you can see the transeptal wire and the fossa itself. Once we cross with the wire from the IVC up into the left atrium, we use the delivery sheath in order to floss on that wire, in order to make the septostomy in the interatrial septum a little bigger. And the reason why we do this is because we want to actually pass our ice catheter into the left atrium in order to give you direct visualization of that left atrial appendage as you perform the procedure. So here you're seeing that catheter floss back and forth between the IVC and the SVC. Subsequently, you're going to see that ice catheter become here or move here into the left atrial space in order to give you this direct image of the left atrial appendage, for which then once you put the ice catheter in the left atrium next to the delivery catheter, like you see it fluoroscopically, you're able to visualize that appendage directly. You're able to derive other imaging planes through the X-plane, and you can actually even do some digital steering like you see here with elevation width, where you basically can elevate the image with digital steering without having to move the ice catheter much. As you can tell here from the ice catheter, we're getting the delivery system or the delivery sheath into the left atrial appendage. There's a pigtail catheter coming into play, and subsequently the device is slowly being brought up into the sheath. Here you can appreciate the catheter being filled with contrast, and an appendogram is being done in order to inject dye in that appendage in order to get a sense of the anatomy, but also the depth of the catheter from fluoroscopy. Subsequently, this is the point where once you get your catheter into position, you will start releasing the device within the appendage itself. In this case, the Boston Scientific Watchman device was used. And as you can see here, fluoroscopically, at least on the right panel, looks pretty good, in a good position. if we look at our ICE imaging from the beginning, once we started basically releasing the device forms very nicely within the appendage. You can see that it has a very nice waist where you can appreciate the compression of the device, suggesting that it should be stable. And it is one of the important aspects of the pass criteria for which we would use to say if this device is sitting well and is ready to be released or not. In this case here, you can appreciate the multiplanar imaging where you can see the blue line cutting from two different panels, the green box and the red box. And eventually here you can get a round watchman and you can actually get your measurements in order to calculate your compression rates. Here, we're seeing it in what we call the supramitral view, where we can actually put the ICE catheter almost on top of the mitral valve and look upwards towards this device, and just a different angle in order to visualize the appendage. Because at the end of the day, Sam, we're doing a preventive procedure, and the promise to the patient is to prevent strokes. And leaving any gaps around these devices because of not visualizing it really makes then this procedure not something beneficial, but perhaps even maybe harmful, because now we actually stop anticoagulation right after these procedures and just put them on dual antiplatelet therapy. This is the TE at 45 days, showing a completely occluded left atrial appendage with no leaks around the device. You can see it here with from the TE, well seated, no device-related thrombus on the face of it, and overall looks good.
This is a really great case and really fascinating case to show. One is step-by-step how you should do ICE for this kind of specific case. But he also showed two things really quickly, just to point out to the audience that ICE also provide you not only just a 2D picture, it showed you 3D reconstruction and also color Doppler, which basically can help you tell if there is any perivalvular leak. So is the theory behind the ICE trial maybe also looking into ability to assess perivalvular leak intraoperatively, interprocedurally more accurately, just because you're right there sitting basically in the same chamber?
Yes, absolutely, Sam. So what we're planning to do in that clinical trial is at 45 days when you do your TE, and that's basically when you turn on the light, patients that were done with ICE and TE will be assessed. We will be looking for leaks around the devices. We know now that even though the IFU for these devices allow up to 5 millimeter of peri-device leak or PDLs, but now there's more emerging data suggesting that really any peri-device leak has been linked to stroke events. And so we have to be very mindful in leaving anything behind. Our goal, and we should strive to leave nothing behind and take our time. There is a deceiving aspect of the intracardiac echocardiography in guiding this procedure is that, yes, you are right there, but if you don't visualize all the parts around the device itself from different angles to make sure that you did not miss any gap or any leak, then it may look good, but then at 45 days, you may be missing a leak or so. So that's definitely part of the things that we're looking at in our clinical trial.
Excellent. Excellent. No, thank you for sharing this case, really interesting case. Looking forward to hear the next case, which is 3D ICE and TEER.
Yep. Thank you, Sam. So we didn't touch much on tricuspid TEER, but tricuspid TEER, as we know, has shown now benefit in improving quality of life and more recently reducing rehospitalization. So there has been a rise in the utilization of tricuspid TEER, and especially now with the expansion of CMS's coverage for doing this procedure. And so for a procedure that is meant to reduce rehospitalization and to improve quality of life, doing it efficiently but also safely and perhaps get the best result is key. And one of the biggest things is TEE has always guided us through all these structural heart procedures, but because of the tricuspid valve being the most anterior valve of the heart, the ultrasound probe sitting in the esophagus all the way back can be sometimes a problem and has to traverse. So looking at this diagram, if you look here at the image on the right, this is your ICE catheter sitting in the right atrium, looking at the tricuspid valve directly. But if you look at a TEE, TEE is sitting all the way back into the esophagus and actually will be looking through all these structures in order to get to the tricuspid valve itself. So if you have some sort of a mechanical valve or prostheses within the heart that may cause some artifact, you may not be able to achieve or get the images that you're looking for. With that being said, there has been significant differences, obviously, between the TE probe and the ICE probe. And obviously, the current TE probes are much more powerful than ICE. But what we're saying is, how can you complement TE with ICE catheter direct visualization over the tricuspid valve itself? These are examples of having the ICE catheter sitting in the right atrium, giving you exactly the leaflet characteristics and the grasping view of the tricuspid valve while you do the procedure. So for example, this is an 82-year-old with severe symptomatic tricuspid valve regurgitation that was referred to our heart valve clinic. And despite diuretic therapy, the patient was referred for consideration for tricuspid tear. At this time, we've considered a dual femoral vein access, right common femoral vein for the TriClip device, and left common femoral vein for the Vericite ICE catheter via the 10 French sheath. We heparinize, and our plan was to use a hybrid approach, which is what we have implemented in our program. And thankfully, with that specific technique and algorithm, we're able to finish those procedures much faster and with even better outcomes. So the TE's purpose is to really get you baseline images looking at the tricuspid valve. This is really the mid-esophageal view looking at your tricuspid valve, which appears to be somewhat redundant with annular dilation, likely related to AFib, and as well as some redundant tissue and degenerative disease. Subsequently, if you take a look at the other images from the derived mid-esophageal views, you can appreciate that there is some dropout even in the 2D images. When the device comes up, you can appreciate here that the TE is sitting in the stomach, and you have the ICE catheter sitting in the right atrium, right next to the device. That's the power of really using both. Here is the image of the ICE catheter, visualizing the amount of regurgitation directly with the ICE, with two different planes that are 90 degrees apart, a -45 and a +45. And here's 3D imaging as well. You can see here, appreciate the 3D enfosse of the tricuspid valve with the regurgitation. We're putting the aortic valve at 5 o'clock, giving you an idea of that this is the septal leaflet, the anterior leaflet, and the posterior leaflet. So these are just different cuts from how we would look at from the ICE catheter. So baseline TE and ICE images are obtained. This is how we get our transgastric view, which is very important. I've labeled it here to show the anterior leaflet, septal leaflet, posterior leaflet. This is the aorta and the aortic valve. And hence, now you're trying to identify the lesion that you're trying to treat, which is in this case, a significant leak between the anterior leaflet and the septal leaflet. So as I scroll backwards, this is the leak, and this is really where we start intervening. So from TE perspective, this is a TE probe sitting in the stomach, and that's how we identify that we're likely going to start treating from the anteroseptal commissure and going back. Navigating, the device from the inferior vena cava to come down from the SVC down to the valve itself is done using the transesophageal echo, although it can be done obviously with ICE. You can imagine that this can be done very quickly and very easily. And again, with multiplanar imaging, you can see that being done with the TEE, and you're able to navigate and bring the device close enough to the leaflets in order now to do what the TEE is asked to do, which is getting the orientation of the clip arms in the correct orientation of getting it basically perpendicular to the septal leaflet and the anterior leaflet. So for example, if you look here, before we turn the device in the box down here, the device was located from a 1 to 7 orientation, and we knew that we wanted to turn this more into a 2 and 8 orientation. So here you can see that we rotated it based on this gastric view in order to put it in the line of coaptation that we wanted to put in. And subsequently, once we know that the orientation of the device looks good, we start moving now to the leaflet insertion aspect by ICE. And so now that the TE has told us exactly how we want to bring it, or how do we want to orient that device in which position, we use the ICE catheter to tell us how to insert those leaflets within the device. So I can show on this panel on the right, these are ICE images with the device right on top of the leaflet. You can appreciate the high quality of the image and the high fidelity of that leaflet tissue that is being seen crisp in relation to the clip arms. And as the clip arms fall down below the leaflets, you are able to appreciate the leaflets bouncing on top of the clip arms, like you see here in the red box. And subsequently, you still can derive the same 3D images that you get with TEE from a orientation perspective. But in this case, as I said, we like to use both TEE and ICE. And in this case here, we switched very quickly to TEE to confirm the orientation of the device in the 2 to 8 position, followed by essentially confirming that we grasped the leaflets and we closed down the device. So once we confirm leaflet capture here very nicely on intracardiac echocardiography, the device falls and you can appreciate how nice and crisp it is. We start closing down the clip arms, and you can see here that the tissue is getting a little more taut on both the septal leaflet as well as the anterior leaflet in this case. Now you can appreciate that the septal and anterior leaflets are coming in all the way into the device. You can see here that there is not really much of a gap behind this device. There's a little bit of regurgitation behind it, so a lot of times we supplement with a second device that comes right next to it, and that's exactly what we've done to treat what's left from a regurgitation without really taking much of your time. It's essentially repeating the same exact step in order to put a device right behind that initial device in order to give it support, but perhaps even get the reduction in tricuspid regurgitation that we aim for. So again, device coming down to the tricuspid valve. This is what you see on TEE as you come down. Once we confirm orientation on the transgastric view, we put the device in a 2 to 8 or 230 to 830 orientation. And once we're ready to go underneath the leaflet, again, we switch to the ICE imaging like you appreciate here. And in this case, ICE goes underneath the leaflet. We deploy the device once we confirm that we have good leaflet capture. And here you can appreciate on TE that the reduction of tricuspid regurgitation from severe down to what looks like mild at the end of the procedure. And that's really what we strive for in this procedure. And that's how you use really both imaging modalities, transesophageal echocardiography and intracardiac echo, to streamline this difficult procedure, to make sure that you're able to visualize leaflets and, God forbid, avoid any leaflet detachment, which is, if it happens, it's more common on the septal leaflet than the anterior posterior leaflets. Those patients can be treated very quickly. They're sent, home the next day. This is the transthoracic echo the next day, again with mild tricuspid regurgitation, and the patient did well, continues to do well with improvement in their quality of life.
This is fascinating. The transesophageal echo has been a great device to use, but with the mitral, maybe it's more useful. But with the tricuspid, especially with all the leads, sometimes this patient get in the way. And when you put the first clip to get a shadow from the clip, so having that ICE machine definitely complementing it. And you said there has been studies to look at it, and hopefully some data is coming out soon, correct?
Yeah, there has been, just like with ICE and LAO, there is a lot of retrospective information and data, and actually more of how-to papers that are being now published, how to incorporate ICE in the workflow of tricuspid TEER and potentially reduce the times of these procedures. There has been some reports, but obviously nothing to say that this will replace TE or vice versa. I think that we need to get a little more of data on how the complementary TE-ICE combo can help us actually reduce the time of these procedures. As we know, TE, especially in structural procedures and complex structural procedures like tricuspid TEER-SAM, have been associated with esophageal injuries because of the fact that you're going from mid-esophageal down to the stomach and back and forth. And so that has been published. And so in order to avoid that kind of back and forth, potentially having that TE in the stomach and having the ICE to guide your leaflet capture has been really a great improvement in the workflows of this procedure. And that's really what we have adopted in our program, and definitely had made a huge difference in how efficient we are today.
Thank you, Karim, for sharing those two really interesting cases and showing the importance of ICE and the way to use it and how to complement other imaging modality like CT and TE. I want to thank you for spending the time with us. I want to spend the last couple of minutes to discuss one more interesting thing you've been doing that's not related to ICE specifically, but over the last 6 or 7 years, you've really led the force in intracoronary imaging, which different type of imaging. And you've had Dallas PCI as a conference that started small and now it's spread to 3 days, fellow course, multiple very high-end specialists and speakers coming from across the globe. Talk us a little bit about the idea behind Dallas PCI. What are you guys bringing to the table this year that's different than the last couple of years?
Well, thank you, Sam. I want to, congratulate all our team, obviously including yourself, in leading this educational effort. One thing that we're all passionate about, especially in our hospital, is education. And so this is really where it came out of. We saw the opportunity, and as we started with just a conference, or not even a conference, a workshop of 35 people with one live case, fast forward, this is our 7th year of doing Dallas PCI, and we're now expanding it to involve more of a contemporary PCI forum that takes you from the journey of the patient from diagnosis with CT-based analysis and CT guidance in PCI and understanding microvascular disease all the way to the extensive MCS-supported chip procedures as well as CTO PCI. What this year brings is more of a practical aspect. We listen and hear from folks what they are looking for, because we don't want to provide another conference, as there are very large and great conferences around the country and around the globe really that offer superior education. But what we want to bring is the practical aspect. And so day one at the hospital is basically a multi-station, practical, step-by-step performing intravascular imaging, intravascular physiology, thoracotomy, plaque modification, with conversations and discussions with really a whiteboard and class feel. Saturday and Sunday, the following 2 days, are basically didactics that are really practical, that are collaborative with multiple folks from different fields, coming really from across the globe, like you've highlighted, with 4 live cases aired from the Heart Hospital, one of which done by yourself and by the team members, and basically highlighting how practical the science that we're talking about today and how to treat your patients and try to answer those questions for your patients. Because honestly, what we want to bring is something meaningful, something practical, something that will help physicians in their day-to-day practice that may not have time to go to these major conferences. So we look forward to it. We're very excited. Obviously, folks can register online at www.dallaspci.com.
Well, thank you, Karim, for sharing it. And hopefully in the next few years, we spoke to the audience about learning intracoronary imaging and intracardiac imaging. Hopefully we can have that also as part of Dallas PCI, as it's all imaging and complex coronaries, but maybe moving to the structural in the near future. I want to really thank you for spending some of your evening Sunday time with us instead of with family. I really appreciate all the input and the insight and the ideas and the wisdom you shared with us and the audience. And thank you for joining us today.
Thank you, Sam, for having me. Thanks to the whole team.
Thank you so much for joining us on BackTable Cardiology.
If you have not already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend.
If you have any questions or comments, direct message us at _BackTableCards
on Instagram, LinkedIn, X, TikTok, Blue Sky, or YouTube.
BackTable is hosted by Hadi Lisha
and Sami Sayfo.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again for tuning in.
We'll see you next time.